Whenever clinical trial results are disappointing, oncologists move to combination strategies to find a place for a specific therapeutic approach. This is also true for glioblastoma and angiogenesis. The last 5 to 10 years have really been dominated by inhibitors of angiogenesis being explored in clinical trials with overall disappointing results. Clinical development in the field of angiogenesis inhibition is most advanced for bevacizumab. It is clear that this drug has some clinical activity, but approval is uncertain and the future of that drug is not really clear. Yet it is now being combined with one of the new immune activating molecules of the checkpoint inhibitor family, an antibody called pembrolizumab. It is unclear at present whether pembrolizumab has single agent activity in glioblastoma, and both the safety and the efficacy of this drug in combination with anti-angiogenic therapy are also unknown. So this trial tries to answer these two questions by enrolling patients with recurrent glioblastoma, and the patients are either receiving pembrolizumab alone or pembrolizumab in combination with bevacizumab. This means a priori that you cannot really make any conclusion on the activity of pembrolizumab because this is given in both patient cohorts. So essentially this trial will give us some indication on the safety of the combination if we look at patients receiving both drugs, and this is going to be reported and this looks to be safe. Whether the drugs in combination are going to be more effective is not known at present because we have no data on that, and if the data look promising they still will need reconfirmation in a randomized setting. So that's where we stand, a promising combination but very early days for this kind of combination treatment. The determination of the IDH mutation status is now of very great diagnostic importance, and accordingly the authors have examined whether you can predict the status of the IDH gene simply by looking at clinical features and especially at MRI features. So they have looked at scans, clinical features, and have fed that into an algorithm to try to predict whether a tumor would be IDH mutant or not, because biologically the IDH status distinguishes major groups of tumors. This is interesting from a biological point of view. Biology correlates with imaging, but for the patient it will have little implication because the patient will still undergo surgery, because the surgery per se has a role for this disease. So simply knowing what the IDH status will be doesn't change the necessity to do surgery. So it shouldn't convey the impression that we get rid of surgery simply because we can predict the IDH status.